Then I would like to introduce Dr. Claude Guérin. He is a professor of critical care medicine at the University of Lyon in France. And he will talk about rescue therapies. So when the mechanical ventilation fails, what can you do? And this also includes proning of the patient.
Good morning. I have to talk about the stepwise approach in refractory hypoxemia, hypercapnia in patients with ERDS, including prone position, permissive hypercapnia, muscle relaxant, and when to consider extracorporeal support. I have no conflict of interest to disclose, and this is the outline. We are going to go over these different items, but first of all, we have to define what is a severe or refractory hypoxemia. On this table, you have several definitions used in the past in trials done in patients with ERDS, and also the expert opinion, and also the Berlin definition of a severe hypoxemia. You can see that we have different thresholds and different FiO2 and also different durations of hypoxemia that have been used in the literature. Basically, you have a PaO2 over FiO2 very low, less than 60 millimeter of mercury, and their high FiO2 and high PEEP for at least several hours. Let's move on the mechanism by which severe or refractory hypoxemia may occur in ALS patient. The main mechanism is a low ratio of ventilation to perfusion and high intrapulmonary shunts that occur in a dependent lung regions. You have here a CT scan showing a lung with ERDS. You have here the ventral part of the lung, the dorsal or spine part of the lung, and you can see that there is a massive reduction of aeration in those parts of the lung, and there you have a marked reduction in ventilation and with a preserved cardiac output, resulting in very low ventilation to perfusion ratio in those regions, and even VA over Q ratio equal to 0, corresponding to intrapulmonary shunt. There is no ventilation, but still perfusion in those areas. And our goal with our intervention is going to make a better matching between ventilation and perfusion, mostly by increasing the ventilation. It is the main cause of a hypoxemia, severe and refractory hypoxemia. There are, however, additional mechanisms. The one is an impairment of hypoxic pulmonary vasoconstriction, which is a very important phenomenon, which occurs in the normal situation. You have a very good matching between the perfusion that flows in that way and the ventilation in the alveoli there. When you have a reduction, like in ERDS, of aeration, in contact of these alveoli, you have a reduction in pulmonary perfusion to maintain a good matching between ventilation and perfusion due to the hypoxic pulmonary vasoconstriction when it is preserved. And in ARDS patients, when this reflex is impaired, you see that you continue to have some flow flowing through alveoli, which has a very low ventilation, and this impairment in ventilation to perfusion ratio is an additional mechanism for severe or refractory hypoxemia. Additional mechanism is a low PVO2, which is very important because it is related to the hemodynamics. A low cardiac output is indeed associated with a low PVO2, and the lower the PVO2, the lower the PaO2, other things being equal elsewhere. If you have a high oxygen consumption in sepsis, for instance, or if you have a high tissue extraction, you have also mechanisms that are going to promote low PVO2 and hence low PaO2. And finally, an additional mechanism is an increase in the dead space fraction in the non-dependent ventral lung regions. As you can see here, this increased dead space is mostly due to overinflated areas due to mechanical ventilation with too high tidal volume or too high PEEP, and also to low cardiac index flowing through these lung regions. And our goal here is both to minimize ventilation and to increase the perfusion to make the matching between ventilation and perfusion better. So let's move on. The first intervention, which is the prone positioning. Prone position has been shown to improve oxygenation in the majority of the patient and sometimes dramatically. And the main mechanism for that is the recruitment in the dorsal spinal lung regions, leading to a reduction in shunt, and also may occur a better matching between ventilation and perfusion throughout the lung after having put the patient into the prone position. A second and very important mechanism, maybe more important than the previous one, is the prevention of ventilator-induced lung injury by prone positioning, and this is going to more homogeneously distribute aeration, ventilation, perfusion, and intrapulmonary shunt that is going to minimize the stress and strain and also to make them more homogeneously distributed. I will come back in the next slide on the homogeneous distribution of these physiological parameters. And finally, and I will come back on that later, prone position is able to preserve hemodynamics. Here you have an evidence for a better oxygenation by using prone positioning. What you have here is the PaO2 over FiO2, the mean values and standard error to the means, over time, during 10 days, in the first randomized controlled trial done in Italy, and it is about patients randomizing to the prone arm. The red symbols are for the baseline supine position, and the blue squares after 1 hour in prone position. You see the dramatic increase on average in PF ratio after 1 hour in prone, followed by a further but slightly increase in PF ratio during the subsequent 6 hours. And then when the patient went back to supine, you see that the oxygenation also went down, but remains above it was at the baseline before prone positioning. And the prone position has a unique advantage to facilitate the homogenization of aeration. On this very early study done in the CT scan, you are the gaze over tissue ratio, meaning that the higher this ratio, the more the gas and the less tissue into the lung. You have that from the most anterior or ventral or sternal part of the lung, if you will, to the most posterior dorsal or supine parts of the lung. In supine position, there is a progressive decrease in this ratio with the spinal lung regions, meaning that you are going to lose more and more air in the prone position. And if you flip the patient to the prone, you see that in the dorsal lung regions, which are now non-dependent to the gravity, are going to gain air, whilst it is compensated by a loss of air in the ventral lung regions that are not dependent to the gravity in prone position. But at the end, you see that the distribution of this ratio, gas over tissue, is very much more homogeneous across the lung in the prone position. It is the main mechanism of action of prone position. This was also very very well demonstrated in this study in sheep. Just concentrate on these two images here, which are taken in the most dependent part of the lung and in the most caudal part of the lung. And these images allows the quantification of intrapulmonary shunt. And you have here the aeration, the gas fraction, in the same areas. And if you see, it is in supine, and when the sheep were prone, you see that there is a marked reduction in the shunt. The same regions here have a very much lower shunt because they will get more aerated. And as a whole, you can see that with the prone position, you have a better and huge homogenization of aeration, shunt, perfusion, and ventilation. In humans, what has been shown is a reduction in hyperinflation by the prone position. The hyperinflation is shown here in supine and then in prone. It is reduced just by proning the patient. And also it has been shown that prone position can induce alveolar recruitment because you see that you have in prone less non-aerated lung and you have more well-aerated lung. This was confirmed in another study. And in this study, Cornejo and co-workers additionally showed that prone position was able to minimize during the breathing cycle the recruitment. The recruitment was what is named the atelectroma, and also to minimize the hyperinflation at the end of inspiration. So with all these mechanisms, the prone position is really able to protect the lung from the further mechanical stress coming from the mechanical ventilation. And finally, prone position is able to preserve hemodynamics. It is just to remind you what are the causes of shock during ERDS. There are two main reasons. The first is a septic shock, because sepsis is the first cause of ERDS. And the second cause is a cardiogenic shock due to either a myocardial involvement due to the sepsis or pulmonary hypertension due to the microthrombi in the pulmonary circulation that occur during ERDS. Pulmonary circulation is going to promote acute cure pulmonale and also right ventricle function that may also stem from the myocardial involvement due to sepsis, which is also able to promote a left ventricular systolic dysfunction. And what has been shown with the prone position is first a reduction in the right ventricle afterload, and hence an improvement in the right ventricle function, and also a reduction in the duration of shock. In our trial, and I will come back on that later on, we found that the patient spent 2 days greater without shock in the prone as compared to the supine position. And finally, this author found that an increase of cardiac index in the prone position in patients with a preload dependence in supine position. This is shown here. They investigated 18 patients in supine and then in prone position. All patients had a severe ERDS. Half of them were preload dependent, were not preload dependent, sorry, in the supine position. And you see that in prone, cardiac index didn't change. Whilst in those patients who were preload dependent with this passive leg rising maneuver in the supine position, prone position was able to increase cardiac index because probably prone position is going to recruit the non-straight vessels and increase the venous rupture. I would like to move to the clinical results. And you have here on this table the 5 largest trials that combine humans supine to prone position. These trials have been published during the last the last 15 years. And you see that the first 4 trials were negative in terms of survival. There is no statistically significant difference between the 2 groups in terms of survival. But the individual data of these first 4 trials were meta-analyzed. And it has been shown that in those patients with a severe hypoxemia defined by a PF ratio less than 100, prone position was associated with a better survival. And we designed, performed, and published 5 trials, the PROSIVA trials, that included a specific subpopulation of patients with ERDS, with a PaO2 over FiO2 ratio less than 150 millimeter of mercury, with an FiO2 of 60% or more, a PEEP of 5 centimeters or more, intubated for at least 36 hours, and they were included after a stabilization period of 12 to 24 hours. And the prone position sessions were performed on 17 consecutive hours on average. Patients received 4 prone position sessions on average. Proning sessions were stopped from predetermined stopping criteria recorded in supine positions. And at the end, you see that we got a very marked reduction in mortality. Here, a very marked increase in survival in the prone as compared to the supine group of patients followed over 3 months after the randomization. Prone position is an easy technique, but it requires organization and education of the caregivers. You should have a written protocol available in your ICU, included video. You have to provide the caregivers with education and teaching session, and to regularly reassess the caregiver for that. 3 to 4 caregivers are needed for the procedure. The physician should be either directly involved in the procedure or informed on the procedure and present in the ICU. One caregiver should be at the head of the bed to control the artificial airways and to guide the team. And beforehand, before the procedure, it is very important to secure artificial airways and the vascular line to reduce the risk of side effects. The next item is a permissive hypercapnia, which is a key issue. And the primary goal of permissive hypoxemia is to protect the lung by reducing the pressure and the volume you set at the ventilator, and that is going to be transferred from the ventilator to the patient. And hypercapnia should follow from this primary goal, but it is tolerated at some point. And actually what counts is the pH to keep within this range of 7.15 to 7.20. And to implement the permissive hypercapnia, you have to use low tidal volume, and you have to start with a 6 ml per kilo predicted body weight, and to measure the plateau pressure and to keep it below 30 centimeters of water. You have also to have defined oxygenation target and to maintain PaO2 between 55 to 80 millimeter of mercury, and to monitor plateau pressure and this and PaO2 regularly, let's say every 6 hours during the first day. And why should we do that? Because of this trial, the ARMA trial, published 20 years ago, that showed a 10% reduction in mortality in patients received a low tidal volume, 6 ml per kilogram predicted body weight, associated with a plateau pressure below 31 centimeters of water. The survival was better as compared to the control group who received 12 ml per kilogram predicted body weight as a control group. Another method to deal with the severe to refractory hypoxemia is to use muscle relaxants. This is based on the fact that muscle relaxant can improve oxygenation, reduce inflammation not only into the lung but also in the whole body through a reduction in the systemic inflammation. And also because muscle relaxation can allow a better control of dyssynchrony between ventilator and patient's respiratory muscles activity, in particular, a very troubleshooting dyssynchrony, which is a double triggering through which the patient is going to receive 12 ml per kilogram, 12 ml per kilo predicted body weight tidal volume, even so you set a 6 ml per kilo predicted body weight tidal volume. In a first trial published 10 years ago, enrolled early ARDS patients selected because they were at the time of inclusion with a PF ratio less than 150 millimeters of mercury and a PEEP of at least 5 centimeters of water, cis atracurium continuous even infusion at this dosage for two days versus placebo. Those patients had a better survival. And in both groups, the sedation was deep with a RAPE score reached to 6 scale. Recently, however, a very large trial coming from the US in ERDS patients enrolled with this criteria received exactly the same amount of cisatracurium but no placebo in the control group, showed no difference at all in survival between the two groups. It should be mentioned that in addition to this trial was not placebo control, the level of sedation was different between the two groups. And finally, when all the previous methods, the reduction in tidal volume, the muscle relaxation, the prone position, failed, and the patient has still a severe hypoxemia as represented here, with a PaO2 over FiO2 less than 50 millimeters of mercury for more than 3 hours, or less than 80 millimeters of mercury for more than 6 hours, or a pH less than 7.25 with a respiratory rate up to 35 breaths per minute, you may consider ECMO. In the most recent large trial, the survival in the ECMO group was higher than in the control group, but the difference was not statistically significant. But in this trial, ECMO was able to save life in patients with a very severe hypoxemia. And here you have a picture of a patient receiving prone position whilst he is under ECMO. And it is my last slide showing some expert recommendation. I've taken them from the French National Society of Intensive Care Medicine, published last year in Annals of Intensive Care. And you can see the step-by-step implementation of the different strategy we have been discussing, along with the severity of a PF ratio. Before concluding, I may add that we didn't talk about the positive and expiratory pressure, and this can be addressed, I think, in another talk or during the discussion we might have. Thank you very much for your attention.
Thank you, Professor Guérin. Allow me to briefly summarize what you taught us. You explained that hypoxemia is the result of a mismatch between perfusion and ventilation of the lung. This can be due to large consolidations in the lung. It can be due to a low cardiac output, and it can be due to vasodilation of the pulmonary arteries that should vasoconstrict in areas that are not very well ventilated. And you showed us that proning can improve this ventilation perfusion mismatch, and it also improves cardiac output, and that it decreases mortality in ARDS patients in which ARDS was due to sepsis and all kinds of causes. So my first question would be, do you think that prone positioning is in COVID as effective as in the trials that you showed us? What is your idea?
In the COVID-19, we have no trial comparing supine to prone. So we have no, high level of evidence. So we just, if we assume that COVID-19 is a ARDS like a non-COVID ARDS, we might, transfer the results we got in the non-COVID-19 to the COVID-19 areas. So we have no a defined answer to your question because we don't have trial. However, what is interesting to observe that the rate of use of prone position in COVID-19 ARDS patient was very high. In what is in the reports we have, prone position was used in more than 60% of the patient, whilst before COVID-19, the rate of use was very much less than 20%, even in the most severe patients. So it looks like the clinicians have adopted this strategy, even so we don't have trials in COVID-19. And moreover, prone position has been used in awake patients before intubation in COVID-19 patients. So that are indirect, reasons for an efficiency of this strategy in the COVID-19.
Mm-hmm. Okay, another rescue strategy that you discussed was permissive hypercapnia, which is the limitation of the injurious mechanical ventilation settings, so lowering the tidal volume, lowering the pressures. And I think, and correct me if I'm wrong, I think that permissive hypercapnia should be applied in all patients with gas exchange that is compromised, COVID or non-COVID, the same. If you agree with that, or do you have other thoughts?
That's correct. It must be mentioned that some author reported that we might have two kinds of COVID ARDS, those with a low, high compliance, and those with a low compliance, and that may allow the clinician to slightly increase the tidal volume if you have high compliance. But we must be very cautious about that and consider that the rules of the minimizing the tidal volume are the same in COVID-19 that in non-COVID-19 patients. But again, no trials comparing low to high tidal volume in COVID-19 ARDS patients.
No, so not many trials, so we have to keep a practical approach, I think. So from the rescue therapies that you listed, do you think that there is a specific order? So first we should apply proning and then muscle relaxants, or is there another order?
I would say first the muscle relaxants and then the proning.
Okay, and in the proning, if a patient's PaO2 does not improve, should we continue?
It's a very good question. It is likely, or it is possible, that the impact of prone position may be effective, even so there is no change, there is no improvement in oxygenation, because prone position can protect the lung, and this effect may be disconnected from an effect of gas exchange. So unless the patient is going to deteriorate, to worsen gas exchange during prone position, we can continue even so there is no improvement in oxygenation. And this is what we did in the PROSEVA trial. We continue unless we had, after 2 prone position trials, a worsening of PF ratio. And furthermore, it may be that what is more important, if you assess the response in terms of gas exchange of prone position, CO2 is maybe a better target than oxygenation. Even so, we don't have really proof evidence about that. But for sure, oxygenation alone is not a sufficient target, to say, I stop proning because I have no a better response in terms of oxygenation.
Okay, so your advice is to apply proning in all severely hypoxemic patients with ARDS, regardless of whether or not their PO2 improves, and perhaps their PCO2 is also important to monitor. So from a practical standpoint, what is your advice about the schedule? How long should they be on the prone, and when should patients turn? And you may consider also being very practical during a pandemic. What would be the best time to prone, considering perhaps less healthcare workers working in the night?
Yeah, it's a very good question. Theoretically, if you assume that a prone position is efficient because it promotes it reduces ventilator-induced lung injury, as long as the patient receives mechanical ventilation, you should put the patient in prone, meaning 24 hours a day. Actually, what is recommended, what has been shown, is beneficial by using long sessions of at least 16 hours. I understand your point about minimizing the rotations, because you minimize the risk of transmission of infection to the caregivers. That is an argument for using long session. And when you have, depending on your organization, when you have the maximal available caregivers in the ICU.
Okay, thank you. Then my last question, because if all this fails, we move to ECMO. Could you briefly list the most important contraindications for ECMO?
As a contraindication will be are probably obvious, a patient with a underlying comorbidity, underlying disease, which preclude active, very, very active care, coagulation disorder, and a very high severe acute condition with a probability of die very high.
Okay. Thank you for your very clear explanations.
You're welcome.
Bye-bye.